I think we can start now. What do you think, Doctor? Dr. Hanan, can we start? What do you think?
Yes, we can start. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everyone, and welcome to tonight's webinar. My name is Dr. Hanan Al-Fadala. I'm GBPD Director and Head of the Program of GP and In-Service Training Committee, Central Department of Primary Health Care, MOH. Tonight, I have pleasure to introduce today's presenter. Tonight's webinar is of 2 CME accredited points. A recorded version of this webinar will be available, inshallah. We'd love to hear from you. I would encourage you to post your question in the Q&A box. Question and answer session at the end will be held to answer all your questions. And tonight we are pleased also to announce that we extend the admission period of GBPDP admission till end of May. And there will be, inshallah, 30 seats available this year. The program is accredited by the KIMS, and the KIMS, under the authority granted to it, will issue a specialized certificate diploma in general practice. And tonight we are pleased to welcome Dr. Talal Altaweel, who is a distinguished gastroenterologist in Kuwait. And tonight he will discuss with us a very important topic, dyspepsia and GERD. Thank you, Dr. Talal, for being with us tonight. Dyspepsia is a very common problem, but unfortunately there is no study for dyspepsia in Kuwait. We don't have any numbers. Maybe Dr. Talal, he is having. طبعا dyspepsia is one of the most common GI problem that people experience at some point in their lives. While dyspepsia and heartburn originate in the upper GI tract, dyspepsia can arise from the gastroduodenal region and manifest in epigastric pain or burning, discomfort, bloating, postprandial fullness, and early satiety. Dyspepsia and heartburn associated disease such as gastroesophageal reflux disease are considered different entities. However, there is a significant overlap between them, and they can coexist in some individual, which complicate the exact diagnosis in this group of patients and making some challenges for our GPs. And it accounts for 5% of all consultation in primary care. This is according to a study done in UK. And dyspepsia appeared to compromise about 70% of the patient gastrointestinal problem in a large prospective survey carried out in general practice in England, higher than some other estimate. Gastrointestinal disease in general practice account for about 5% of all consultation. And a study done in Kuwait and Saudi Arabia, the prevalence was 60%. This is the most يعني أقرب شيء لنا is Saudi Arabia. Ladies and gentlemen, please join me in welcoming Dr. Talal. He's a graduate from Aberdeen University School of Medicine, Scotland, completed internal medicine residency in Kuwait board certification, MRCP UK and MRCPS, completed his residency training in gastroenterology and at McGill University, Canada, completed 2 advanced fellowship in inflammatory bowel disease and therapeutic endoscopy at McGill University, currently practicing as a consultant gastroenterologist and as head of the gastroenterology unit at Jaber Al Ahmed Hospital. authored numerous publications in the field of inflammatory bowel disease, and he is an active participant in the Cochrane Inflammatory Bowel Disease and Functional Bowel Disorder Review Group. He is one of the founding council member of the Kuwait Gastroenterology Association. With that, kindly give your full attention to Dr. Talal and join me in welcoming him to the stage. Dr. Talal, حياك الله. The floor is yours.
Bismillah wa salatu wassalamu ala Rasulullah. Assalamu alaikum. I'd like to start really by thanking Dr. Hanan for the kind invitation to participate in your training program. It's actually, the pleasure is mine really to interact with my colleagues from primary care. It's always a pleasure to do that. We don't see each other very much, especially with COVID, but at least it's nice to be able to interact with our colleagues even outside the sort of the hospital setting. And I'd like to thank also AstraZeneca for kindly sponsoring this event. So I'm gonna start by sharing my slides. So just hold on, sharing my screen. So hopefully it'll work. Okay. Okay, so can you see my slides?
Yes, Dr. Talal.
Okay, excellent. Okay, so the topic that was assigned to me was how to deal with dyspepsia and GERD in 2022. The actual initial topic was just dyspepsia, but then I was told by the committee then also to add GERD. And because so that made the presentation a bit longer, because as Dr. Hanan said, they're no longer considered to be the same disease, although the patients might share the symptoms at the same time, but they're actually quite different. They have a different pathophysiology and different management. So I'll be speaking about them in two different parts. So these are my disclosures. Right, so these are my objectives. So as I said, I'm gonna tackle each one separately. So we're gonna start with dyspepsia. We'll talk a bit about definitions and causes. Then we'll talk about the role of Helicobacter pylori infection. Then we'll mention the alarm symptoms and the indications for esophagogastroduodenoscopy or an upper gastroscopy, upper GI endoscopy. And then leave you with sort of a brief management algorithm that you can, as a take-home message. And then we move on to GERD and talk about sort of the pathophysiology and a bit of a diagnostic flowchart for GERD and what are the categories and complications of GERD. And then we'll touch on management and then a bit about PPI safety. And hopefully you can leave here with some useful take-home messages. So we'll start with dyspepsia. So the word dyspepsia, when we start with, as you know, most of the medical terminology either comes from either Greek or Latin, and dyspepsia means it comes in two words. So dys means bad or abnormal or difficult or impaired, while pepsis is digestion. So what it means is basically bad digestion. And it's not a diagnosis, but rather a symptom complex. So that's quite important. So dyspepsia is not the diagnosis, but it's actually just a description of what the patient complains of, and you try to reach a diagnosis for the symptom complex. So this is what's the Rome 4 definition. So remember, the Rome group is now this is their fourth iteration. So they're a group that look to deal with functional GI disorders, where they come up with diagnostic criteria for each GI disorder. So the Rome 4 defines dyspepsia as epigastric pain, epigastric burning, postprandial fullness, or early satiety. So one or more of the following. And it shouldn't be called dyspepsia if the predominant symptom is heartburn or acid regurgitation. So actually they did separate them there. So it's basically discomfort in the upper part of the abdomen. So this is what dyspepsia is. So it's important to know when we mention that word, for example, in your referral letters, so that's what you mean, because there's a lot of overlap. So sometimes you might get IBS with dyspepsia, and the patient might be labeled as dyspepsia, or IBS, but it's really when it's dyspepsia is upper abdominal discomfort in the upper abdominal region. So we no longer use the word gastritis. So I noticed that this is used a lot by a lot of people. The patient presents with an acute gastritis. So gastritis is actually a pathological diagnosis, histopathological. So this is gastritis is only when what you find on a biopsy of the stomach when the pathologist sees gastritis. So this is now what's the proper definition of gastritis, when there is a inflammation in the pathology, but clinically should be called dyspepsia rather than gastritis. So this part will be of the presentation will be based on two guidelines, the latest guidelines. So the American Journal of Gastroenterology, the ACG and CAG, the Canadian, the American College of Gastroenterology guideline. There was a joint guideline published in 2017. And more recently, a couple of years ago, the UEG, or the European guideline for functional dyspepsia, was also published. So the guideline is based on the lecture is based on these two guidelines. So the CAG or ACG definition, as I said, it's a symptom complex of epigastric pain or discomfort that's thought to originate in the upper GI tract and conclude any of these symptoms: heartburn, acid regurg, burping, belching, bloating, nausea, feeling of abnormal slow digestion, or early satiety. And as Dr. Hanan mentioned, the prevalence of dyspepsia is quite high, and it's been reported around 20 to 40% prevalence, with an incidence of around 1% per year. And 70% of these patients that present to you with dyspepsia actually have what's called functional dyspepsia, which we'll speak about in a little while. It has a significant reduction of the patient's quality of life, and importantly, also it's a significant economic burden to the healthcare system. So these patients tend to remain symptomatic, with over half of them using medications, around 40% having GI procedures at 1 year. So it just indicates how intensive this problem is in terms of use of medical resources. So what are the causes of dyspepsia? Well, the causes sometimes of dyspepsia, although the patient is complaining of dyspepsia, might be reflux, esophagitis, although we'll speak about GERD, but the patient sometimes has difficulty telling you what they have. It could be a lot of the time a peptic ulcer disease, and it could be just like a gastritis or duodenitis, which is usually Helicobacter associated. Very few patients, here says under 2% can have cancer, especially in the West or anywhere in the world other than the Far East. And as you can see here, that over a third of your patients that present to you with dyspepsia have actually normal endoscopies. So this is, I'm speaking about endoscopy. So they end up having a totally normal endoscopy. As you can see, a large number, it's actually normal findings in endoscopy. And we'll speak about how to deal with that later on. So Helicobacter, obviously, its role in peptic ulcer disease has been well documented since Marshall and Warren got the Nobel Prize in the 80s, when people thought ulcers were because of stress. And they revealed that most of these were because of, especially duodenal ulcers, were Helicobacter pylori associated. It's a group 1 carcinogen in humans in terms of causing cancer. But as we know, very few people that actually get Helicobacter develop gastric cancer, because we think it's multifactorial, depends on diet, depends on genetic factors and smoking and whatnot. So actually reassuring the patients a lot of the time, because if they Google it, they'll notice cancer comes up first, but actually very few people get cancer. And around half the world population has Helicobacter. So you can see that the incidence is pretty low, except in certain places like the Far East. And it is cost effective to treat for in dyspepsia if the prevalence in the population is over 10%. So if you have a prevalence over 10% in your population, then it's actually cost effective to look for Helicobacter. If it's less, then it's actually not. And you might be better off just giving proton pump inhibitors. Now, the question is, Dr. Hanan was speaking about whether there's any data in Kuwait. Well, I did do a search looking at our local data to look at the HP prevalence here in Kuwait to try and decide whether it is worthwhile checking for Helicobacter. What we came up with was, my search was, so there was this publication published by my colleagues in Amiri Hospital, led by Dr. Walid Al-Azmi. And what they did is like they looked at patients who were already having dyspepsia, who were referred to undergo testing, and around half of these were positive for H. pylori. So among the symptomatic patients that you guys might refer, most of them are actually positive. But you remember, the guideline says that the overall prevalence in the population should be over 10%. Now, this is not overall. This is biased towards patients who are symptomatic. So do we have any studies looking at the overall prevalence of HP in Kuwait? Unfortunately, we do not have any full publication. The only one that I came across was actually a poster that was presented at the Kuwait University Poster Day around 6 years ago by Dr. Jabir Al-Ali, who's a colleague at Mubarak Hospital with a few medical students. And what they found here is what they did. I think I remember Jabir, when I spoke to him, they went to the Mujamma al-Wuzarat and they tested people at the door, basically with a finger prick test that measures antibodies. And what they found here is that around 17% were found to have IgG antibodies against Helicobacter. So we presume that's our best guess, that our prevalence is around 17%. So it might, based on the limited data that we have, I think it would be worthwhile to check for HP in our dyspeptic patient. Now, this is sort of an older algorithm that wasn't mentioned in the new guideline. I liked it though, and I think it suits, is still applicable, especially to primary care, because it gives you more of a holistic view at the possible causes when the patient presents to you. Because obviously when they present to you with so-called dyspepsia, there could be also other possible causes. So with this algorithm, what we do is that someone comes to you with pain or discomfort in the upper GI region. What the first thing you should do as a primary care physician is check for other causes, remember. So you shouldn't just use tunnel vision and look at one thing. You should look wider. So you rule out cardiac, obviously, if there are risk factors, hepatobiliary, medication use, dietary indiscretion, or whatever. And if you find another cause, you treat as appropriate, right? So that's very important. So a good history and a physical exam will sometimes find the answer pretty quickly in these patients. Remember, like cardiac disease can mimic GI diseases. Obviously, you have to look at risk factors and the patient's presentation. So if they don't, next step would be, if you think it's GI, then you would be looking at alarm features or age. So is the patient over 60, or do they have alarm features like vomiting, bleeding, you feel an abdominal mass or dysphagia or unexplained weight loss? If they do, then you would consider referring this patient for an endoscopy. And the usual alarm symptoms, I mean, they vary, but the ones in terms of upper GI neoplasia, you think of things like recurrent vomiting. You think you might be worried about gastric outlet obstruction, significant unintentional weight loss. So remember, it has to be unintentional. If the patient's trying to lose weight, then this is intentional and this is fine. So when it's unintentional weight loss, hematemesis or melena, unexplained iron deficiency anemia, an abdominal mass on physical exam, dysphagia, or having an age over 60. However, although we all use alarm signs, when you actually look at the data, you can see that alarm signs are really not as good as we think they are. And this was a systematic review, meta-analysis, looking at over 57,000 patients, which is evaluating the value of alarm signs in detecting upper GI neoplasia. And they found out of all these patients, only 0.8% had cancer. So you can see the risk is extremely low. And out of these, if you look at the sensitivity and specificity, it was only in the 60s in detecting GI neoplasia. So it's actually not very, not as good a tool as we think in detecting neoplasia. What about clinical opinion? So what the physician's global assessment or opinion, how does that weigh in detecting upper GI neoplasia? What they found here is that it's actually very specific, very few false positives, but it's actually not very sensitive though, with only sensitivity of around 29%. So what do we do then? Are alarm signs any good? Should we use them or not? Well, you should consider them definitely if there's a prominent alarm sign, like extreme weight loss, over 10 kilos, or rapidly progressive dysphagia. Now, this is really worrisome. Or if a combination of features was present. So that's important. So if you had multiple alarm signs. So remember, current data has not evaluated combinations. So you still need to, or severe symptoms, so you still need to evaluate on a case-by-case basis in these patients using clinical judgment. The risk always increases with age. So obviously your threshold to refer a 58-year-old compare a 28-year-old is different. When you have an older patient with alarm signs, obviously it's more worrisome than maybe a younger patient with alarm signs. And a family history of, for example, upper GI malignancy would also be an important thing to ask about in your history. So really it's individualized. You can't put a blanket statement, but you would need to assess each patient separately. So next, say the patient doesn't have alarm signs, what do? You ask about your medications. You ask about non-steroidals or aspirin use. And if they do, then you should try and address that. So remember, we said Helicobacter pylori is the most common cause of peptic ulcer disease. However, non-steroidals are responsible for most of the other ulcers. So they're actually quite important. So what do we do when they've got you think it's non-steroidal induced? Well, can you stop it? If yes, stop therapy. And if the patient's better, then that's it, job done. If not, you can't stop it. Then you have to think about what to do. So can you maybe give a PPI? Can you give a cytoprotective agent like misoprostol? Give high dose H2 receptor antagonist, which we don't do anymore really. But if any reason you can't give a PPI, maybe switch to a COX-2 selective COX-2 inhibitor. And always remember to eradicate HP, just in case you forget. If the patient needs to stay on non-steroidal for a long time, then you should try always to make sure that you find HP and eradicate it. That will really decrease your risk. Now, another question was about what do we do with non-steroidals? Now we're mentioning them. Obviously, this is a different talk, but it's relevant to what we're saying, that if you've got a patient on a non-steroidal, you need to give everyone PPI. Well, it depends. So the GI risk and the cardiovascular risk. So if the patient has a high GI risk and a low cardiovascular risk, then you should consider either alternative therapy or don't give the non-steroidal, or give a COX-2, for example, with a PPI. And if the patient has, a high cardiovascular risk where you can't even give a COX-2, then you should avoid them altogether. But really, I mean, here, in terms of giving a PPI, it would depend on what the GI, mainly the GI risk is. So if you have a sort of like a moderate to a high GI risk, and what's a moderate to a high GI risk? Well, it would be things like, basically, if the patient is an older age, that's one risk. If the patient has a history of peptic ulcer disease or a complicated ulcer, if the patient is already on another anticoagulant or antiplatelet, for example, these are considered all high-risk patients or moderate to high risk. So these are the patients you would consider always giving a PPI with your non-steroidal. However, if you have, say, for example, a young patient, you got a 25-year-old coming with an injury, a fracture, for example, that has no other risk factors, doesn't have any previous peptic ulcer, not on an anticoagulant. So this patient you would absolutely not need to give a PPI to. However, when you get an elderly gentleman with aspirin, maybe also one of the new anticoagulants, so this is a completely different ballgame, and this is a patient you would consider giving a PPI. So I would encourage you to look at this publication. It's very useful with this very short summary of it, just to tell you about how to risk stratify the patients regarding PPI and non-steroidals. So just moving on. So the patient is not on a non-steroidal, so what do we do? Well, you look, is the dominant symptom heartburn or regurgitation? So is this patient really describing to you heartburn rather than dyspepsia? So if it is, then you would treat it as reflux, and that's the second part of the presentation. We'll speak about that. Now, the patients know this is definitely dyspepsia, so it's a GI. We've ruled out alarm signs and other things. So what do we do? So is the HP test positive? And this is usually by UBT. Now, serology can be used if the test has been validated against another modality. Now, a lot of our tests in Kuwait that are here, the serology have not been validated. So we actually don't recommend using serology a lot of the time. And as much as you can either use the urea breath test, or even there's a stool antigen test now, which is much, much better than serology. Serology, remember, if you use it, you can only use it to diagnose HP, but you cannot check for eradication. So the antibodies stay positive all your life. So you can't check for eradication, but you can check, if you don't have any other tool, you can use them if you want. But it's definitely much better not to use UBT or a stool antigen. And if they're positive, you would treat them as HP positive. I won't get into the treatment for Helicobacter because that's a completely different talk, which I'm more than happy to give at a later date. Now, functional dyspepsia is what we call, remember, what we called initially when the patient comes to you before endoscopy is called uninvestigated dyspepsia. So this is totally uninvestigated. Now, when the patient has been scoped and there is no evidence of structural disease at upper endoscopy to explain the symptoms, this is when we call it functional dyspepsia, okay? And there are two types. So you have the epigastric pain syndrome, where you would, the main symptom is epigastric pain or burning, while the other type is when the patient has more of a motility issue. So they would be complaining mainly of postprandial fullness, usually in the upper stomach rather than lower, postprandial fullness and early satiety. So they cannot finish the meal. And it's slightly different because the management is slightly different in terms of maybe use of prokinetics in this second type. So just in summary, give you a take-home message of the algorithm for the treatment of dyspepsia. So if the patient is over 60, you would start with endoscopy straight away. And if it's there is any abnormality, you would treat that or abnormality according to what it is. If it's normal, then you would manage it as either with for example, a PPI or with the algorithm on the right side, where you would give basically a PPI trial for this patient. I'll show you here. So what happens here, if the patient's under 60, you would do an HP test and treat. And as we said, it's recommended to do it with a urea breath test or a stool antigen. If the patient is positive, then you would just eradicate the HP and then check for eradication with another test a month after completing the eradication. And if the patient responds and it's eradicated, that's it. We've got a happy patient. If the patient is negative for HP, or for example, has no response to HP eradication, which is very possible, that's when you'll be giving the PPI trial. And this is usually a standard dose PPI once daily for 8 weeks. This is what we usually give. So once daily standard dose PPI for 8 weeks. If the patient doesn't respond to PPI, here is where I would consider an EGD before I go to say the patient is, for example, functional, and you'd go to neuromodulators just to make sure there is nothing going on. And if the patient is deemed to have a normal EGD, failed PPI, HP negative, then this is when you would call them functional, and you would consider trying your neuromodulators, for example, tricyclics or an SSRI. Although tricyclic, the data is better for tricyclics. You can consider using a prokinetic, especially in the patients that have a postprandial distress syndrome rather than the pain. And if there's no response, then you would think about other things like psychotherapy or other modalities. Okie doke. So that's part one done. Hanan, do you want to answer the questions now or just at the end?
At the end, please, Doctor.
Okay, that's fine.
Thank you.
Okay, look. So the second part now we'll get in. So for the next 15, 20 minutes, what we'll do is we'll talk about GERD. So this is actually a newer guideline. So the GERD guideline has been updated very recently, November of last year. So this is a very new state-of-the-art management of GERD from the American College of Gastroenterology. It's published in what's called the Red Journal of the American Journal of Gastroenterology. So what's the definition of GERD? And really, the definition of GERD is there's an older one, which is 1999 from what's called the GenVal workshop, and then there's the ACG new one. So basically, it's the condition where there's reflux of gastric contents into the esophagus that causes symptoms. So this is what GERD is. And objectively, you'd be defining it. That's the symptoms. That's the pathophysiology. But you would define it as objectively, ideally, by seeing erosions on endoscopy, or if you don't see them, then you would have an abnormal, what's called a pH study to confirm GERD. How do you define it objectively? So there's subjective or symptomatic description, and there's objective description using endoscopy or a reflex monitoring study. So it's important to know how GERD occurs, because it's quite important to when you explain it to your patient. So what happens with GERD? It's actually not due to, not just due to, for a lot of people think it's just hyperacidity in your stomach. The acidity actually in the stomach can be normal in a lot of the time. What happens though is the LES, lower esophageal sphincter, is impaired, and you have prolonged relaxation of the lower esophageal sphincter. So basically it's supposed to deliver, the esophagus, remember, delivers the food to your stomach, and the LES would open to deliver the food and then would close most of the time. It might open intermittently, but a lot of the time when there is no delivery of food or fluid, it would just close. What happened with people with GERD is that this esophagogastric junction, or what's called the anti-reflux barrier, is impaired, and it's actually loose. So it's open more at a time when it's not supposed to be open. And that's when you get the reflux of the gastric juice into the esophagus that causes the symptoms. Because remember, the esophagus doesn't have a protective barrier to protect it against acidity like the stomach. So what are the symptoms of GERD? So there are actually quite a few symptoms that can present as GERD. So the most common, obviously, it's heartburn. And it's important to know when you explain to the patients, when you ask the patients about this. So heartburn is عندنا الحارج أو الحرقة. The patients feel, and which is a burning sensation from the epigastrium up to the neck. Obviously, it can be cardiac as well. So remember, it can mimic other causes of disease, but this is the most common. Then what patients always tell you, عندي ارتجاع. And it's important to know vomiting from regurgitation, they're different. Vomiting is an active retching. So there is a vomit is different to regurgitation. Regurgitation is effortless. So the patient would get effortless regurgitation of acidic material into their mouth. So it feels the acid in their mouth effortlessly after a meal. While vomiting is different, is when they actively retch and vomit. So it's actually different. Chest pain can be almost the same as cardiac pain, and the cause can be GERD. And then there are some extraesophageal manifestations, which we'll talk about. So how do we diagnose GERD in 2022 now? This is the ACG 2021 diagnostic flowchart, which I think is useful for everyone, especially in primary care, because that's when they come to you first. So when patients come to you with classic GERD symptoms without alarm signs, and you've ruled out, for example, other causes, then what you do is you'd give them an 8-week trial of once daily PPI. And it should be that long, really, the trial, because to heal any esophagitis, most of the studies need 8 weeks. So it should be a long trial of PPI. If they have a complete relief of GERD, then you just stop the PPI. However, if they have incomplete relief or the symptoms recur, then you would consider doing an EGD of PPI, and then you'd see if there's any esophagitis and you've confirmed GERD. If it's normal, then you would consider maybe doing reflex monitoring, and then if it's normal, you'd look at other causes for the symptoms. So this bit is maybe left to the gastroenterologist, but definitely the upper part here, a lot of it is in the primary care would see this part really. And even this part here, if you discontinue the PPI, it was classic GERD, you give them PPI for 8 weeks, say, and it recurs very mildly, you don't necessarily need to refer them straight for an EGD. If they're young and healthy, you can give them as required PPI, like for a few days when it comes after they finish the 8 weeks, for a few days whenever needed, or maybe alginates like Gaviscon, for example. And if that relieves their symptom, then it's fine, and as well as lifestyle changes, which we'll speak about. So not everyone needs an EGD. It's important. A lot of them can be managed just with PPI therapy. Remember, with PPI, just to let everyone know, you have to know your doses of PPI, of the different PPIs, and know what's the standard dose from a double dose, right? So we don't need to give double dose to everyone. Especially we'll speak about PPI side effects and all that, although it's safe, but you should always try to give the lowest effective dose. So these are the usual doses. I think in the polyclinics you have omeprazole, and this is always 20 milligram once daily. And remember, always focus on the before breakfast, 30 minutes before a meal. If they take it after a meal, it doesn't work at all. So if before you say the patient did not respond, always ask them, when do you take your PPI? You'll be surprised how many patients take it after the meal. And it's completely useless. Even if they take it at bedtime, it doesn't work. If they're going to take an evening dose, they take it before dinner and not before bedtime, right? And the double dose is BID. And these are the rest of the doses of the different PPIs here. So you can have a look at the slide at your leisure, and just make sure you know these doses when you prescribe them. And the GERD prevalence is really underestimated, and around patients wait sometimes 10 years or more before presenting with GERD in their primary care setting. A lot of patients, as we said, up to half of them use antacid. They just go to the pharmacy and they use over-the-counter antacid. 18% consulted a pharmacist, and then around 56% consulted a physician. So as you can see, that a large number of patients don't even see the doctor. So a lot of them would come to you maybe even very, very late when they've had long-term GERD. And what are the categories of patients with GERD? Well, with GERD, there are two different. So there's erosive esophagitis, or there's non-erosive reflux disease and erosive reflux disease. So the majority of patients, meaning that what's called NERD, is patients who have no erosions on endoscopy, while these patients that have erosive, it means they have erosive esophagitis on endoscopy. And out of these, obviously the patients who have esophagitis are worse in that a large number of them, or significant number of them, will get complications, which we'll speak about in a second. So why are we worried about reflux? Why is reflux an issue? Well, because if it goes untreated, it can cause complications. So number one, it can cause reflux esophagitis, which will show you a few pictures of that. And basically, it's erosions or ulcers that you see in the esophageal mucosa caused by the acid reflux. If this continues on, you can get a reflux stricture. So you get luminal narrowing of the esophagus, and patients present with dysphagia because of the ulceration, healing, and then ulceration, then healing by fibrosis. And then the other thing is, obviously, when they get chronic reflux, you get Barrett's esophagus, which is a change of the esophagus, esophageal mucosa. Remember, it's squamous epithelium that you see in the esophagus, while in the stomach is columnar epithelium. And what happens is that the squamous epithelium of the esophagus changes to columnar, an abnormal change. And the worry is that if this continues, then that might change to a dysplastic cells, and then up to malignancy later on if this is left without check. And this is obviously the most worrying thing, is the esophageal carcinoma, which is our worry of long-standing GERD. So what about the esophageal? So do we have any extraesophageal syndromes? Well, we do. So these are the typical esophageal syndromes you get with GERD. Reflux, you get what's called also reflux. So typical reflux, you get reflux chest pain syndrome, and you get things that are complicated, causing injury in the esophagus, like reflux esophagitis, reflux stricture. We spoke about these in the last slide. And then you get also what's called the extraesophageal syndromes that are associated with GERD, with reflux of acid. So there's something called reflux cough, reflux laryngitis, reflux asthma, and reflux dental erosions that are usually referred by other specialties to gastroenterology to treat GERD. And these are some of the proposed associations that haven't been proven yet, but these are the established ones that have been. So when you see the endoscopy, when we're looking for esophagitis, we look when you refer someone, it's important for us to know what the indication is, because we look closely at what's called the GE junction to see if there is any damage. So this is what's called the esophagitis, erosive esophagitis. So this is the 4 grades. So this is where you have grade A, B, C, D, and you can see the severity of the ulceration is more when you have when you go down the grades with more involvement of the esophageal mucosa and longer ulceration. And the problem is that you can't really tell the patients that have NERD or GERD, so they all present with almost similar symptoms, or whether it's heartburn, regurgitation, or whatnot. So you can't really tell that with just by symptoms. So it usually goes, you have to do the endoscopy to tell these patients apart. Now, what can you do we'll speak about therapy, but what can you do in terms of diet and lifestyle? And is that important? Because we do a lot of that advice to the patients, but is it actually based on evidence? So this is actually the latest recommendations from the latest guidelines. So when you tell your patients, you make sure you don't deprive them of things that don't have good data. It's easy to tell the patient to stop everything and not eat anything and not enjoy life, but you really destroying their quality of life here. So you need to, I think this is good really to know what's most effective advice that you can tell them. So the first thing is weight loss, and weight loss is extremely important in GERD. There's a lot of postulated theories is the diet, the high-fat diet can promote reflux, and the increased intra-abdominal pressure can also increase reflux. So we always promote obesity, and this is, someone had bad GERD, that's another way to promote weight loss, to try and tell them it will alleviate their GERD symptoms. Avoidance of meals between 2 and 3 hours of bedtime is very important, because to make sure the food has exited the stomach with less chance of having GERD. Avoiding tobacco products, because start smoking will decrease the LES pressure. And then in terms of foods, trigger foods. So there's 2 classes. So there are foods that are thought to reduce the LES pressure. And I think this is important to stop those. Things like alcohol, we spoke about smoking, chocolate, peppermint, and high-fat foods have been shown to decrease the LES pressure. And you tell the patient, try and avoid these. Now, in terms of things like excessive caffeine, citrus, and coffee and spicy foods, they actually don't decrease your LES pressure, but are just irritants. So you tell the patient, you can try it. If you feel it annoys you, then stop it. But if it doesn't, you can eat it. But definitely these ones here, you tell them to reduce it, because it does reduce the LES pressure, and elevation of head at bedtime for the nighttime GERD symptoms. So this is why the recommendations based on the data, just to look at them. So most of them are actually recommendable, the ones we just said, in terms of avoiding most things. For example, the things that are irritants, like avoid citrus. For example, yes, if citrus triggers symptoms, because it's just an irritant, it doesn't actually harm the esophagus. If it irritates the patient, and that's what I tell them, you try it. If it irritates you, then stop it, which is the way I usually tell them. Smoking, I always tell them that's a good way to tell them to encourage to stop smoking. In terms of coffee, I think because it doesn't decrease LES pressure, you don't deprive them of coffee or tea, right? So I'll see a lot of patients, they come, they're dreaming of having their coffee in the morning, and they say, I've been told I can't drink it and all that. So I tell them, drink it in moderation. Caffeine can irritate you, but I know as physicians, we all know how we want our morning coffee in the morning to be able to work. So it's unfair for us to tell the patient not to have theirs. So this is an up-to-date recommendation on what to tell the patient in terms of lifestyle changes. Now, after you start your PPI, remember we said 1 pill daily for 8 weeks. So what do we do? So if it's just NERD, so the patient has NERD or mild esophagitis, then you can just start the full dose PPI once daily for 8 weeks. If the symptoms are controlled, they can consider stepping down and giving them on-demand or what's called lowest effective PPI dose. So you don't necessarily, the patients have mild esophagitis or just non-erosive, you can give them as required therapy or just the lowest effective dose that they can, like even every other day, for example, have patients taking, or 3 times a week, for example. If the patient has severe esophagitis, that's C or D, or has Barrett's, then you would need to give them long-term maintenance because the majority of the patients will recur. So it's very important to get initial control with an 8-week trial. You can sometimes even consider increasing the dose if they don't get controlled, but not everybody needs long-term PPI. So it's just those that are with severe esophagitis or have Barrett's esophagus. What do you do with the extraesophageal manifestations? So these are the strongest associations. You need a detail. The first thing is you need a detailed medical history to identify the causes. Very important first to refer them to other specialists first and make sure that there's no other cause for the cough, the laryngitis, before you investigate for GERD. If you're going to treat the extraesophageal manifestation, you should give a twice daily PPI, so you give high dose. If there is also GERD symptoms. So if someone has a cough with heartburn, then you would treat them. You would give them, and let's say, for example, has cough, cardiac cough, and GERD. The pulmonologist said there is no evidence of asthma, spirometry is normal. Then this patient, you would consider giving them twice daily PPI and see if they improve with the cough. However, if the patient just has cough with absolutely no GERD symptoms, I would refer this patient to GI first before giving them a PPI trial. And why is that? It's not the harm of PPI, but it's actually because there's a placebo effect with PPI. So a lot of patients, if you give anyone a PPI, a lot of patients have an improvement, but you don't know if that's because they got better because of GERD or they got better because of placebo. So it's important that if they don't have GERD symptoms, then you actually, and you've worked them up for the cough, that you refer them for reflux monitoring first to confirm GERD before you treat it. Now, I'm just going to give my final 2 slides is really around PPI safety. Now, this is a talk on its own, so I'm not going to get into it totally, but this is a very nice statement that actually the ACG wrote it in their guideline and actually tell you to tell your patients that. That's why I have it between apostrophes there. So this is actually what they recommend you tell your patients when they ask you. Because المرضى يجونك يقولوا لك دكتور الآمن الارتجاع حبوب الارتجاع التغليف على قولتهم آمنة, are they safe? So this is what to protect yourself, this is what you say. So PPIs are the most effective medical treatment for GERD. Some medical studies have identified an association between the long-term use of PPI and the development of numerous adverse conditions, including intestinal infections, pneumonia, stomach cancer, osteoporosis, CKD, and deficiencies of some vitamins, minerals, heart attacks, strokes, dementia, and early death. This is what's mentioned, right? Because they read that when they Google. But then you tell them, those studies have flaws, are not considered definitive, and do not establish a cause and effect relationship between PPI and adverse conditions. So they were associations, but none of them were cause and effect. The high quality studies have found that PPIs do not significantly increase the risk of any of these conditions, except for intestinal infection. So there is a higher risk of intestinal, even the non-C. diff infections are increased in patients with PPI, but that's the only thing that came up. However, because obviously medical data and science changes all the time, we cannot exclude the possibility that PPIs might confirm a small increase in developing these adverse events. So that's why what we say for the treatment of GERD, we believe as gastroenterologists or even as primary care physicians, that the well-established benefits of PPI outweigh theoretical risk. It's a very nice statement. So you protect yourself. You say, yes, there are some studies that associate PPI with all these different things. However, they have a lot of flaws and do not show there is direct causality. The high quality studies do not show these and show only a minor intestinal infections. We cannot rule out that there might be a small effect, but the benefits more than the risk, and you would only give it to your indicated patients. And that's why we always consider down to prescribing PPI when you don't need it. So always go to the lowest effective dose. So final slides, ladies and gentlemen. So GERD continues to be the most common disease, among the most common seen by gastroenterologist surgeons and primary care physicians. Diet, lifestyle changes are important and effective, and non-pharmacological means of managing GERD. PPIs are the backbone, and primary care physicians should be familiar with their indication, dosing, and duration, and be aware of when to refer to a specialist for evaluation. Thank you very much.
Thank you so much, Dr. Talal, for your simple, informative, and great presentation, very practical. We appreciate your helpful comments and recommendation that produce a nice guide for our GP. We have 13 questions right now. We will start. Salamat, Dr.
I'll just come back in a second. I'll leave this on.
Salamat, salamat.
بس شارك شوي دقيقة هرجع لك. I'll leave this on for the disclaimers. Just 1 second. Okay, I'm back. So
سلامات دكتور طلال.
الله يسلمك. لا عندي شوية لارنجايتس ف شاركت شوي.
لازم تتأكد إنه ما عندنا ريفلكس.
البي بي اي موجود.
دكتور في سؤال من دكتور محمد محمود. What is your valuable advice regarding over prescription of PPI?
Excellent question. Well, it's not a problem بس بالprimary care. It's a problem everywhere. بالمستشفى أكثر actually. لأن we get a lot of repeat prescriptions والدكاترة يجددون الوصفة without checking. It's a big problem everywhere.
دكتور سام عندنا نفس الشيء.
المشكلة وصفة تتجدد because الضغط على الدكاترة وما عندك وقت to review it. So that's why we have there's a lot of suggestions. Sometimes now there is a role of clinical pharmacist now. الحين عندنا بالمستشفى قاعدين where they review their prescriptions ويسألون do we need that for example that PPI prescription, even other medications. But we should, I think the way we do it and we should worry يعني have a balance. يعني الحين الstudies صدق are negative and the PPIs are safe. لكن كل مرة تطلع study about PPI because they're very commonly prescribed. So we cannot 100% guarantee in the next 10 years there won't be a study that will relate PPI to something. فإحنا, and that's why we cannot tell the patient نقول لهم based on current data ما في, بس في signals and في associations although they're weak studies. So what we do is we should give our indicated patients and give them the right dose, the lowest effective dose for the shortest duration. That's what we should do. أغلب الجايدلاينز that تشوفون recommendation indications are 8 weeks. Very few patients need more than 8 weeks continuous PPI. يعني عندك very few. قلنا Barrett's, قلنا severe esophagitis, لكن الغالبية المرضى اللي قلنا do not need long-term PPI, and you can give them either on demand when they require, which is fine, or the lowest effective dose.
Thank you, Dr. Talal. Another question from Dr. Siham. In some countries, H. pylori infection is considered as a pandemic. How much is this information considered true? And if so, what non-pharmacological measures could be taken?
ما في non-pharmacological بس HP eradication. HP لحد الآن ما في data. All the non-pharmacological measures don't work. They tried probiotics, they tried honey. ما ينفع. The only thing that works is antibiotics. هذه different talk عاد about the regimens كذي. عندي a separate talk. I can give it to you later on إذا تبون about HP.
Thank you, Victor. Question from Dr. Sousan. If recurrence of symptoms happen frequently after stopping the PPI with severe chest pain, what should we do?
If إذا صار recurring وايد, then you'd refer, قلنا بالalgorithm تذكرون, refer for gastro for an EGD. إذا قاعد يصير recurrent وكذا, إذا المريض يسوي منظار ويتأكد إنه ما في شيء causing it. بس إذا ما في شيء بالEGD, everything is fine, or if the patient's known to have GERD and response to PPI, then you would keep him on the lowest effective dose, or what's called like a PRN basis.
Thank you, Victor. They are asking about your advice for patient who is taking PPI during Ramadan.
A very important question. صعب. And the patients ما يحبون, لأن you have to wait half an hour before you take the PPI. هاي المشكلة برمضان إن يبون يفطرون على طول. So what you would do, تعطيه, تقول له عندك two options. يا تاخذه قبل السحور تنطر نص ساعة, or you take it before فطور and you wait half an hour تروح تصلي بعدين تاخذه.
Dr. Talal, what about 2 hours after meal? Is it possible to give PPI or not recommended?
لا, هو لازم قبل الوجبة, لأن that's when the protein, يعني كل مريض راح ياكل, لأن the protein pumps يفتحون لما في شهية. You know, when there's when the brain is thinking, you know, there's a meal, راح آكل, فالprotein pumps ينفتحون ready to release the acid.
Yes.
فإذا بعد 2 hours إذا ماكو أكل مو مفتوحين يكونون, أو مو كلهم مفتوحين, it's not as effective.
Thank you, Dr. Talal. Another question: when a patient presents with indigestion and they have no red flags or indication for alternative causes for their symptoms, how this patient should be managed, and what is the role of syrup Boxal, anti-acid, or Boxal plus in dyspepsia and GERD?
هذا قلناه. إذا ما عنده alarm عندكم الفلو chart.
Flow chart, yes, yes, clear.
إذا ما عنده alarm PPI قلنا. إذا dyspepsia ولا GERD حاط لكم flow charts أنا. إذا عندكم
Yes.
GERD no alarm PPI, dyspepsia no alarm, check for HP. ما في HP PPI. For 8 كلهم 8 weeks usually.
Yes. The role of the anti-acid, please, in dyspepsia.
ما في. In dyspepsia ما في. In GERD, yes, very useful as adjunctive treatment. يعني الانتاسيدز مثل قاعد نتكلم عن رينيز ولا تبون alginates مثل جافسكون, they're good for as required حق mild symptoms. إذا المريض عنده very mild GERD إلى مرة بالشهر, يقول له أخذ جافسكون بس كافي يريحه, that's enough. You don't need PPI حتى. It's useful on someone on PPI إلى breakthrough symptom, يعني ياخذ PPI doing well, بس خلال اليوم بين الجرعتين أو بعد جرعة الPI له واحدة كذي تقول له أخذه as required. You know what I mean? I don't recommend regular use of antacids. تخليه as required either for very mild reflux اللي مثلا نقول less than once a week, or less than once or twice a month, or actually less than once a week, مثلا. And in patients who are on PPI but have breakthrough symptoms that are sometimes not controlled by PPI, ياخذ الجافسكون or alginate or Rennies as required. بس مو maintenance، ما ينفعون. They're symptomatic. ما يسوون mucosal healing اللي عنده esophagitis شيء لا، بس يساعدون السمت.
Thank you, Dr. Talal. Question from Dr. Bedriya Al-Kandari. Is Barrett esophagus reversible by PPI?
No. So Barrett's is not reversible. Once you get Barrett's, it's not reversible, but it prevents progression of Barrett's. Barrett نفسه مو خطر وايد، يعني هو مو كانسر. Barrett معناته البيشنت بدأ يتغير عنده long term GERD وبدأت الخلايا تتغير to columnar. بس انت you worry ان it progresses to dysplastic dysplasia وبعدين adenocarcinoma. PPI just maintains the reflux, protects the mucosa from ongoing damage, but it will not reverse the GERD. No. So once you have Barrett's, ماكو علاج، تعطي PPI and monitor. تسوي له surveillance endoscopy كل 3 سنين، يسوي upper. هذا جايد لاين ثاني عاد نتكلم عنه، انه you survey them، تتاكد ان التشيو نفسه ما تغير. The other thing is ان اذا only GERD اللي تعالجه اللي صار في ديسبليجيا، يعني السيلز تغيرت من just metaplasia to dysplasia، فهذه تحاتيها نسوي لها radio frequency ablation تحرقها. هذه عاد ادفانسد يعني تكون عاد هذا راح المريض اكيد مع gastroenterologist قاعد يتابع. بس no Barrett's if you're saying is it reversible, no. Is it you can limit its progression? Yes, with PPI or lifestyle changes, weight loss, stop smoking, السوالف.
Yes. Thank you, Dr. Talal. One question they are asking about the safety use of PPI with the patient with chronic disease like diabetes, hypertension, and chronic cardiovascular disease.
تكلمنا كله سيف. البي بي اي الديتا تكلمنا اخر ستيتمنت في ريليشن حاطينه. الدايابيتس ماكو مشكله مع الدايابيتس. hypertension ما في مشكله at all.
Osteoporosis.
اي تكلمنا اللي قلت لكم اياهم باللسته، سي كي دي، osteoporosis، نمونيا، مش عارف ايش. كل الستاديز are weak. they're observational. مو causality، ما في causality، only association. it's not, you can tell the patient they're not strong data. The only thing اللي go intestinal infections تزيد، لأن يمكن يقول لك تقلل acidity فيصير more bacteria are able to thrive in your gut، لأن أنت قللت acidity of the stomach which protects. Remember, the acid destroys the bacteria that you eat that get into your GI tract. بس غير هذا كل شيء weak، لكن you still give them the lowest effective dose.
Thank you.
Actually they recommend.
What is the best?
ما خليني اقول يعني حتى دكتور ان القاعده الاخير حتى يقول لك you don't recommend routinely monitoring labs على واحد على بي بي اي حتى long term، يعني الا اذا عنده other reason. يعني واحد ما في healthy قاعد ياخذ 25 year old ياخذ بي بي اي long term تعطيه needs مثلا حق erosive esophagitis، اذا ما عنده مشكله you don't need to routinely do labs حق البي بي اي. مثلا في ناس يكون مغنيسيوم عرفت، يقول لك you don't need to unless في other reason عند other risk factor. لكن واحد ما عنده other risk factors you don't need to even monitor their specifically for the PPI.
Thank you, Dr. Talal. What is the best way to alleviate severe chest pain attacks related to GERD?
PPI. double dose.
Yes.
بال extra esophageal manifestation what's called non-cardiac chest pain. طبعا أول شيء تشيكون إنه مو it is not شو اسمه it is not cardiac obviously رقم واحد. إذا definitely not cardiac then you would give PPI and usually هني تعطي high dose. الextra esophageal manifestation تعطي double dose usually PPI.
Yes, okay. Regarding our hypothyroid patient, the use of L-thyroxine both with PPI because they will take it the same time before meal, morning, early morning.
صحيح هذه ما ادري انا فيها، لان سالوني كم مره. I'm not sure. I would ask the clinical pharmacist. بس انا اقول لهم فصلوها شوي، لان اتوقع ما ياخذون انتم as far as you know more التروكسين تعطون الفير مع ساعات الفير ياخذون المرضى عاده. هذا يقولوا لي يقعدون الفير ياخذونه. البي بي اي تاخذه قبل الريوق، فمو نفس
هو
الوقت.
نفس الشيء الفيروكسيك قبل الريوق بعد.
انا اعرف مرضى ياخذون الفير، ما ادري هو
empty
ياخذون
stomach يعني لازم.
اي بس مو قبل الاكل، يعني empty stomach. فانا اقول لهم فصلوا.
yes
والله انا بين مانج اقول لهم فصلوا.
yes
انا I don't know the data صراحه، ما ادري، لان I would ask maybe a clinical pharmacist. انا اسالوني كم مره اسال الاندوكرينولوجيست he would know more. انا اقول لهم فصلوا، اقول لهم هم اغلبهم يقولوا احنا ناخذ التروكسين الفير. اقول اقعد صاير الفير واخذه. قلت له اوكي. قلت البي بي اي اخذه قبل الريوق يعني الصبح، فاخل بينهم فتره. انا ما احط، بس صراحه ما ادري اذا في specific interaction as far as I know. No.
thank you doctor. They are asking about the surgical repair of GERD. What is your opinion?
هاي قصة عاد يعني no not to start with. تخير المريض يعني it's a big topic هذه، بس definitely if there's a big hiatus hernia يعني في anatomical reason. طبعا الناس اللي تسوي لهم الريفلكس السيرجري ما في كلام، اللي مثلا عنده big hiatus hernia و not responding to treatment يعني هذا أكيد خلاص ما في حل. عنده anatomical defect وتعطيه أدوية وما يتحسن، هذا خلاص هذا متفقين عليه. الناس اللي شوية المو أكيد اللي هو المريض اللي responding to therapy، هل تعطيه تسوي له سيرجري ولا؟ هذا تخير المريض، تقول له تبي treatment تبي surgery instead of medication. في بعضهم it's actually effective surgery, it's better than medication. من ناحية the good surgeon will do يعني can do a good job in reducing GERD. بس لازم تقولوا لهم دائما، نقول لهم دائما it does not stop PPI total. يعني if you do the surgery you might still need PPI later on، بس يمكن الدوز أقل تحتاج. وفي complications of the surgery as well that مثلا it either fails or it's too tight الفندوبلايكيشن، فهذه لازم he discusses مع السيرجن مع the potential side effects. فمو not everyone only those non-responders or patients مثلا اللي ما يبون or عندهم مشكلة إن يكملون PPI long term. هني ممكن تقول له discuss it with them. بس لازم تسوي لهم pH testing و monitoring قبل، يعني a lot of tests before you go ahead and they need to discuss مع السيرجن complications of the surgery.
Thank you Dr. Talal. Are there any contraindications for PPI use?
Allergy to PPI عندي واحد كذي بس not really. ما في absolute contraindication يعني no. ما في real contraindication other than patient hypersensitive to PPI. بالأمانة يعني there isn't really a specific contraindication. I'm trying to think of using PPI الحين with this new data. يعني there is patients يمكن اللي عندهم مثلا severe osteoporosis ولا عندهم severe pneumonias ولا CKD. Yes, I would maybe يعني إذا أقدر ما أعطي PPI okay, but if he needs PPI تعطيه PPI. This is my question. The data is weak regarding these associations.
Thank you. Is dyspepsia and GERD inherited?
No.
What is the indications for هذه خلاص قلتها دكتور surgical جاوبت لهم.
إيه.
هني في سؤال عن use of PPI with pregnancy.
Safe. أغلبهم B pregnancy category B. حيغيروا categories ما يحطون any categories بس they're all pretty safe. بس I'd leave that up to the gynecologist يعني to decide. بس a lot of them يعطون مثلا يعطون PPIs for severe GERD يعني، بس they're quite safe in pregnancy يعني ما في مشكلة.
They are asking about treatment of iron deficiency anemia if the patient is having dyspepsia and GERD.
ما فهمت.
What is your
هذا شيء وهذا
يعني
شيء.
هو
ما فهمت السؤال. هو ايرون ديفيشنسي انيميا شيء والديسبيبسيا شيء، شنو العلاقه؟ ما في علاقه. الانيميا ينفستيجيت انيميا ما له شغل، يعني هذه alarm sign. اذا واحد قصدك عنده ديسبيبسيا وانيميا I would investigate him. هذا يعتبر alarm sign. اذا المريض عنده unexplained anemia وعنده dyspepsia I would investigate. هذا I would send the patient for endoscopy مثلا، لان هذا alarm to see if there's no bleeding for example كذا. You know?
Yes. You have mentioned some foods that may decrease the lower esophageal pressure, but any
Yeah.
medication has this side effect to decrease the lower esophageal pressure.
في a few were mentioned. انا الحين ما اذكرهم، بس الجايد لاين الاخير ما حطوا. they didn't update them. I've read some antihypertensives. اتوقع كانوا حاطين ramipril can do it كنا بس to me الامانه latest guideline ما حطوا، فالassociation is not as strong. في ادويه نستخدمها that will لا to decrease لا، بس عندنا ادويه that increase اللي يعني يقللون الريلاكسيشن كعلاج، مثل باكلوفين نعطيه حق المرضى اللي عندهم ريفراكتوري جيرد not responding to PPI، نضيف لهم باكلوفين يقلل الريلاكسيشن. لكن to my knowledge لا، ما في يعني some antihypertensives I think been associated but in general no. To my knowledge ما يعني آخر guideline they didn't mention stopping حتى any of them. they شالوا موضوع الأدوية.
The antibiotic course.
ايش في antibiotic؟
إذا البيشنت على antibiotic and taking PPI, any advice or what is your opinion?
ادري ما في رول. ليش تعطون انتيبيوتيك؟ ليش تعطون PPI مع انتيبيوتيك؟ ما في انديكيشن، يعني ما في انتيبيوتيك ما له شغل بالبي بي اي يعني. ف unless the patient عنده dyspepsia or GERD قاعد تعالجه that's different. بس يعني giving routinely هذا هنا قاعد نتكلم عن موضوع الروتين يوز بي بي اي بدون داعي. يعني I don't routinely give كل انتيبيوتيك اعطيه وياه بي بي اي، ولا اعطي كل كورتيزون prescription اعطيه معاه بي بي اي. it's not indicated. هني هذا overuse of PPI، هذا over prescribing. ف you don't need to do that.
Okay. How we can differentiate between dyspepsia and GERD clinically, and will it differ in management?
طبعا differs. كل التوك كلها different, completely different.
Yes.
That's a whole talk. يعني تكلمنا شلون two different sections يعني they're different. ساعات بس it's difficult. I can see the question and they're difficult. إن المرضى ساعات يحيرونك أو عندهم both. يعني انتبهوا، المرضى كان have both، عنده dyspepsia وعنده GERD. يعني يقول لك عندي عوارض وعندي حالج and they can even have IBS بعد معه، فعنده كل شيء المريض يجيك باكج. فأنا قصدي إن you would treat كل واحد بروح يعني separate. فمثلا البي بي اي will help both الdyspepsia and the GERD. بس you have to make sure مثلا إذا عنده GERD ما في داعي تدور for HP. إذا المريض classical GERD heartburn regurgitation there's no need to check for HP. ما راح يفيده يعني حتى لو عنده HP. it will actually في كلام أصلا حتى eradication of HP makes the GERD worse يعني. بس that doesn't mean you don't eradicate it. بس أنا قصدي you don't look for HP in واحد بس في GERD. إذا عنده وياه dyspepsia هو pain yes I would look for HP. هذا المين difference. both of them use PPI. الفرق إن dyspepsia you'd also look for Helicobacter pylori.
One question asking about the use of bismuth for bloating.
I don't use it.
Thank you. في one question about how you can choose between the different type of PPI.
ما قصة طويلة، ماكو فرق really. I mean that they've looked at that in detail and there isn't huge difference between the PPIs in terms of efficacy. I mean if you looked at the data comparing the PPIs, not because AstraZeneca is supporting this, but they found that esomeprazole was actually slightly superior in acid suppression compared to the other PPI. لكن the number needed to treat was very high to have a meaningful clinical impact. يعني لقوا إن acid suppression was better but in terms of إذا حسبتها clinically wasn't a clinically meaningful difference when number needed to treat was very high. So really what we tell the patients and whatever PPI works I would take, whatever is available for the patient I would give them. في الحين حكي على إذا المريض ما يبي ينطر half an hour وياكل، وايد يسألونا برمضان إنه ما يبي ينطر نص ساعة هذه قبل الفطور ويعاني، يقول لك لا ما يبي ينطر نص ساعة. There is also the newer PPI dexlansoprazole. This is the ميزته إنه يشتغل over 24 hours. There's a dual peak فممكن ياخذه حتى بعد الأكل. That's the only one. مو أحسن منهم. Just you can take it even after food. That's the only one. بس الأمانة يعني all PPIs whatever is available to you you can give it. Only thing omeprazole انتبهوا إن في interactions أكثر مع other medications لأن it's an inducer. كلهم inducers بس يعني أكثر واحد الأوميبرازول. فإذا في مريض على وايد أدوية immunosuppressants ولا شغلات معينة maybe use something that doesn't interact as much like pantoprazole or rabiprazole. هذول they don't the least interactions. Omeprazole has more interactions. مثلا إذا ياخذ anti epileptic تحاتي omeprazole مع الانتي epileptic مثلا، هذه النقطة. فيمكن هني يصير شوية التشويس، أنا أعطيهم ساعات pantoprazole مثلا. بس غير هذا really I just give them whatever is available to me. المستشفى حتى عندنا كم مرة ينقطع هذا هذا. whatever is available and whatever the patient benefited. أسئلة شنو ارتحت عليه؟ قال ارتحت على هذا. أقول له very good then take this one. Sometimes I switch. إذا المريض قبل لا أقول give up على PPI أحول to another type. Sometimes that helps. But in general they're equivalent to PPIs.
Thank you. We have there are 3 questions asking about the relation between PPI or the use of PPI with antiplatelets like Plavix.
هذا حكي وايد طلع عليها. طبعا there was a lot of talk about this. لما طلعت one of the studies showed نفس الشيء non-causality but association between PPI use, specifically omeprazole or clopidogrel. But then a lot of studies came out and there was an RCT called the Cogent trial. It was negative. There was no association. And now even the Heart Association, the American Heart Association does not consider that there's any significant association between PPI and antiplatelet. So you can give it يعني كنسلوا الحين association. They believe it's only seen in vitro but not in vivo. You're not in real life. Actually, it's protective. A lot of these patients are anticoagulants or they're at high risk of bleeding. فبالعكس a lot of the cardiologists أصلا هم نفسهم يكتبون PPI حق مرضاهم بعد الستنتس وبعد الكاردياك كاث. I would if they need to take it always review the need for it. If they need it you give them. ساعات I avoid omeprazole. ساعات إذا المريض ببدأ على new PPI وياخذ Plavix I would maybe give pantoprazole ساعات. بس إذا المريض عليه already I don't change عادي. فيعني ما في it's been negated. طلع عليها studies yes بس الحين the risk is considered not significant. It's been refuted in newer trials.
Thank you so much, Dr. Talal, for your interesting and evidence-based and patient-centered information. And تعبناك.
حياكم الله. لا
طبعا
أنا بس
احنا لان معظم الاسئله كانت على البي بي اي لان احنا عندنا مشكله between البي بي اي اور patient they are insisting. طبعا هي مع الريفل تنكتب حاليا متوقفه شويه كل البي بي اي عندنا في البرايمري هيلث كير فمرتاحين شويه منها.
لا مشكله بس لان يعني some patients do need it حرام يعني خاصه اللي عندهم ريسك. بس انا قصدي we have to try and select يعني the patients and try to educate them about this. الحين بالعكس والله قاعد اشوف الناس العكس الحين خايفين they come very scared الحين يقول لك في risks كذا قاعدين العكس الحين they're reading a lot about PPIs واتساب يوصلهم على الموضوع يخترعون. It's the other way now also. You have both sets of patients اللي very scared وطبعا اللي يبون PPI all the time. فأنت as a physician you should always educate and tell them what you know and be honest. Tell them medical data changes. يعني هم ما يصير تحلف لهم إنه ماكو شيء وبعد شوي تطلع السري ثانية. But you tell them in the current day and age, based on the current data, this is the recommendation.
في one question, is it allowed to use PPI and H2 blockers together?
Usually no. اصلا ما في الحين H2 blocker بالكويت يعني الحين وقفوا الرانيتيدين ما في الا نزاتيدين بالبرايفت بس يعني اسمه فيكست اسمه بس usually no. في selected patients اللي هم على high dose PPI twice daily وstill عندهم nocturnal symptoms at night ساعات نعطيهم بالليل H2 receptor antagonists. المشكلة مع ال H2 receptor antagonists يصير معاهم tachyphylaxis إن they get used to it بعد فترة they lose the response very fast. we don't use it. تقريبا يعني ما أذكر آخر مرة كتبت أنا H2 receptor blockers صراحة من زمان. no, not really. Very rarely.
One question, what do you think of Dixilant 60 milligram?
هذا ديكسلانسوبرازول قلنا عنه اللي قلت لكم عنه اللي هو قلت لكم اللي ممكن ينعطى بعد الأكل. That's the only advantage. مو أحسن منهم يعني مو ما في data it's better. It's easier for some patients. فوايد مرضى برمضان يحبونه يقول لك عندك شيء فأنا ساعات أكتبه قريب من رمضان أكتبه لأن الناس يبون يأخذونه بعد الفطور وكذي. that's an advantage for it. But it's only licensed for GERD, not for dyspepsia or HB eradication. فاللايسنس ماله بس حق GERD.
One question about the role of domiprazole and GERD.
ما في. No role.
Okay. Thank you so much, Dr. Talal. Please accept our thanks for this enlightening, stimulating, and great presentation. Thank you so much. And we'd like to express our deepest gratitude to our audience for their joining and participation. Special thanks to AstraZeneca for supporting us in running this scientific meeting. Our next scientific activity will be next Saturday, Pediatric Asthma, a Practical Approach by Dr. Saadoun Al-Hassan. Thank you very much, everyone, and good night. Thank you, Dr. Talal. Thank you so much.
Thank you. يعطيكم العافية. Nice to meet you. Hope to see you soon, إن شاء الله.
Thank you so much. Thank you.
Bye bye. مع السلامة.
Bye. مع السلامة.